Well, good morning. Thank you for coming today and spending a Saturday morning with us here. It's really nice to see some familiar faces and also some newer faces too. So for me, it's been really important that we hold these meetings every now and then, but it's exciting to see just the growth within a few of these meetings. My name is Dr. Kelly Baruch. I'm the clinic director here at the Garden Grove Ascend Physical Therapy, and we're joined by a few other staff here. So this is Dr. Joseph Park, our owner. Dr. Jerry Young was checking some people in. You guys will meet him a little bit later. And then he peeked around. And I'll introduce our speaker, Dr. Jen Neely, in a second. Do you guys mind me asking, how did some of you guys hear about this? Because there are some newer faces. So raise your hand if you've been like a patient here with us and found out that way. Okay. Did any of you guys hear about us through like online? That way? Okay. Any through a doctor's office directly? Okay.
Originally.
I heard about the facility from the doctor's office.
Okay, yeah.
Today I found out
Through the
facility
emails.
online.
Okay, perfect. Well, yeah, thank you so much. This is newer for us. We just started this since COVID this year. So I've always told everybody I would love feedback just to see if there's topics that you guys are interested in, or ways that we can modify it to kind of suit your guys' needs more and more each time, okay? Your speaker today is Dr. Jen Neely. She has been with our office for the past 6 years. She graduated from PT school at Cal State Long Beach and has been with us since. I know some of you guys are probably patients of hers and you know what a great skilled clinician she is. I'm super happy she's presenting on 3PD. It is a little bit of a newer topic, and it's a newer diagnosis that not everybody, even in the medical realm, is aware of. So we're here to hopefully help clarify things, answer your guys' questions. I'll have her speak, and then after that we're going to go into a little bit of a breakout support group where it can be a little bit more specific to your guys' own individual questions. But if you guys can put your hands together, this is Jenny.
All right, thank you so much everybody for coming. I'm very pleased to be presenting on persistent postural perceptual dizziness. It is somewhat of a more newly defined diagnosis, so like Kelly said, I'm very happy that we're out there educating the public and the medical professionals on how treatments for 3PD can be beneficial for these patients. It is somewhat of a mouthful of a diagnosis, so you'll often hear it referred to as 3PD or triple PD. So if I refer to it as that, this is what persistent postural perceptual dizziness is. Can everybody see okay, or do we need to dim the lights a little bit?
I always love the lights. But that's just me.
That's perfect.
Is that better? Okay. All right, so just to start off with, we are going to go over a little bit of the anatomy. So we're going to go over our 3 different balance systems. And if you're a patient here, I'm sure you've heard this 100 times. But we have 3 different balance systems that we utilize to keep us steady. So first one's going to be our visual system. That's our ability to see. Second one's going to be our vestibular system. And what that is our way to determine where our head is in space. So whenever we're moving our head, that's that vestibular system that's being activated. And our last system is called our proprioceptive or somatosensory system. What that is just our ability to feel where our body is in space. So for example, if I close my eyes and move my hand, I can't see what my hand is doing, but all those receptors in my hand is telling my brain what my hand is doing. All 3 of those balance systems have to work equally together in order to keep us balanced and steady. And when we have mismatch of information between those balance systems, that's where we get dysfunction or disorders, which can lead to imbalance and dizziness. So we're just going to kind of go over the history of 3PD. Originally, when this first started, Scientists called it agoraphobia, or fear and avoidance of situations and places. They somewhat defined it as a psychological disorder, which we now know today is not the case. So in 1986, some German neurologists actually got together and kind of redefined this as phobic postural vertigo. And we'll start to see some of the research as PPPD. And what they found is that this was a postural dizziness not associated with vertigo, where it dealt with fluctuating unsteadiness and was provoked by social stimuli, so being in like crowds. And then in the early 2000s, they defined it as chronic subjective dizziness, where it's a non-vertiginous dizziness and unsteadiness that was increased by a person's own motion. And it was with exposure to environments and complex or moving stimuli, it actually increased those symptoms. And then in 2014, a bunch of scientists got together under Jeffrey Staub, and we redefined what that dizziness was, and now it's called Persistent Postural Perceptual Dizziness. They kind of got together and made this specific criteria so that it was easier for people to diagnose this. So what exactly is 3PD? So it's a chronic functional disorder of our nervous system, which is our body's control center, characterized by a non-spinning vertigo and a perceived unsteadiness. So now they've learned, okay, this is not a psychiatric disorder, but rather a neuroautologic disorder. So dealing with the brain and the ear, or the vestibular system. It's also conditioned by behavioral elements such as like anxiety. So to kind of break down what all those letters stand for, P is for persistent. So they found that on most of the days and most of the days of the week, this dizziness is going to be there. So it's more of kind of this constant dizziness, not so much this episodic dizziness that kind of comes on and then is no longer there. It's postural, meaning that it's worse in certain positions, primarily in upright and moving positions. And perceptual is kind of the definition or that criteria that really makes it that 3PD, where people feel this self-perceived movement and visual stimulation is very provoking. Visual stimuli is kind of that visually enriched environments where you have lots of different patterns or colors, where that visual system's kind of on overdrive. And then last one is going to be dizziness. And what that is a disorientation of space or unsteadiness. So in 2014, when these scientists actually got together, they made this diagnostic criteria, because 3PD is actually a clinical diagnosis, meaning that we don't have any specific tests that are going to say, hey, you have 3PD. It's different than, like, say you had a fracture and you broke your arm, got an x-ray, and you can see that that's what that diagnosis is. Being a clinical diagnosis means that we are going to diagnose based off of signs and symptoms. So when they got together, they made this criteria to say, okay, if you meet these 5 different points, then we can diagnose you with 3PD. So first one is going to be that one or more symptoms of dizziness, unsteadiness, or non-spinning vertigo is present on most days for at least 3 months. And it's kind of important to kind of understand the difference between what dizziness and vertigo stands for. You know, a lot of people get those 2 words kind of muddled. Vertigo is defined as like this true spinning sensation where either you are seeing spinning or you're perceived that you're spinning. Whereas dizziness is more kind of defined as like a rocking or a swaying or a tilting type sensation. Second criteria is that persistent symptoms are provoked in certain positions. It's typically going to be in upright postures, with motion, and with visual stimulation. So when you're in like visually complex environments. These events are going to be triggered by a certain event of vertigo, unsteadiness, dizziness, or have a problem with imbalance. Symptoms are generally going to cause significant distress or functional impairment. So most of my patients will report, this really impacts me every day. This impacts my ability to do activities, my ability to work. And then last is that you have to rule out to make sure there aren't any other diagnoses that might be potentially causing these symptoms. So it can be a little bit confusing in a sense of how to diagnose somebody with 3PD, because 3PD can actually coexist with other diagnoses. So it is kind of important to know that, like, some people might have, for example, BPPV, where your crystals are loose, or vestibular migraines concurrently with that 3PD. Excuse me. So you might have episodes of vertigo, but also still be diagnosed with 3PD. So before we kind of go into the pathophysiology of what causes 3PD, I did want to introduce this concept called neuroplasticity. This is a really great concept to kind of understand how we learn in our environments. So the brain has the ability to modify, change, and adapt both structure and function throughout our life in response to experiences. So this is essentially how we learn. So if you take the concept of learning how to ride a bike, when you first ride that bike, it's really challenging. But over repetition, over time, it gets easier and easier, right? This is called adaptation, where you're building these neural connections between the brain, okay, these pathways in the brain. And though you might not have ridden this bike in a few years, if you get back on that bike, you're able to do it, right? It's because it's a learned thing that your brain has adapted to. There's also this concept called maladaptation, where you have ineffective or not appropriate adjustments to the environment or situation. And this is kind of what happens with 3PD. Okay, so this is a little bit busy of a graph, I apologize. But I do think it's a great way to kind of explain what's kind of going on. I'm gonna try this pointer. So here, we have an initial onset for PPPD. It's typically going to be either a vestibular crisis, a medical event, or an acute anxiety attack. So vestibular crisis, research has found that BPPV and vestibular migraines are kind of the leading diagnosis for that. And then psychological triggers can be like anxiety or panic attacks. And what happens is that after this onset, you get this acute adaptation. And this is normal. This is how our body responds to a specific trigger. So what happens is that when you have this vestibular crisis, our body says, hey, this vestibular information is not correct. So what I'm going to do is I'm going to rely on those two other balance systems, so the visual system and the somatosensory system, to try and keep myself steady. Okay? And then we get this high-risk postural control strategies. And that's essentially where you're kind of on guard. And this is where I'll see my patients kind of coming in like this and walking and turning like this. Because that vestibular stimulation is going to provoke more dizziness, we compensate and we learn different ways to avoid those motions that are going to cause us more symptoms. And then environmental vigilance, that's just essentially us being aware of the environment and things that might potentially cause us more symptoms. So typically what we should see is that after this acute adaptation, our body recovers, and then we have recovery where we're no longer having symptoms anymore. But with 3PD, this is where things kind of go a little bit haywire. And the leading theory is that 3PD is caused by persistent overdependence of the visual system now. So we're no longer using those three different balance systems equally. We're relying very heavily on the visual system. And what happens then is we get this failure of readaptation, or that maladaptation we talked about, where now we have this perpetuating loop where things just gradually worsen. So we also have these comorbidities up here, such as anxiety, phobic disorders, depression, which actually increase that perpetuating loop. Provoking factors are going to be pretty much what we learned about in that diagnostic criteria, where upright positions, motion sensitivity, and visual sensitivity are going to play a part. So when we get into this perpetuating loop here, what we want to do is get back to this recovery stage, right? And what we need to do is self-directed neuroplasticity, where you're intentionally trying to restructure or rewire that brain back to the way it should be, okay? And we'll go over treatments a little bit about how we can do that. So a little bit about prevalence. 4% of all patients that were registered with their general practitioner experience persistent dizziness, with 2% of those diagnosed with a vertigo or dizziness diagnosis. 15 to 20% among all patients presenting for an evaluation of vestibular symptoms were actually diagnosed with 3PD. The average age for 3PD is going to be in the mid-40s, but it can actually happen at any age between adolescence and late adulthood. And there is a female predominance over males. So in terms of the incidence rate, they did a study in 3 to 12 months follow-up of patients. Investigators found 3PD like chronic dizziness or persistent, we call visual vertigo, in about 25% of these patients, despite already compensating or recovering from that initial onset of dizziness. After acute or episodic vestibular ailments, they found that these 3PD-like symptoms were actually prevalent in 1 out of 4 patients. So that's a significant amount of people that are having these 3PD-like symptoms. In terms of risk factors, anxiety and depression can increase your likelihood of developing 3PD. 60% of patients with 3PD had clinically significant anxiety, but that's also going to increase with a diagnosis of 3PD. 45% of patients had clinically significant depression, where 25% of these patients had neither. So 3PD, I think, is something that we need to make sure we're seeing clinicians that truly know about this diagnosis and know how to treat this diagnosis. It is a complex and evolving condition, which it requires a lot of expertise in a multidisciplinary healthcare team. So, as a physical therapist, I am constantly in contact with the doctors and things like that to make sure that these 3PD patients are getting the best care possible. And this is just a list of different doctors that you might end up seeing if you have 3PD. So if you went to your doctor in terms of evaluation and testing that they might do, medical testing is going to be done to kind of rule out and make sure it's not something else that's potentially causing those symptoms. So EKGs to rule out if there's cardiac problems, blood work, imaging such as MRIs or CT scans to rule out if there's anything going on neurologically. Vestibular testing, VNG and ENGs, what are those are going to do is kind of determine how well that vestibular system is functioning. Audiograms are going to check for your hearing. That vestibular system is situated very closely to the hearing center. They actually share a common nerve. So a lot of vestibular disorders can have hearing changes associated with it. And then positional testing for BPPV, that's if you've heard of your crystals being loose, and balance testing to determine how well those 3 different balance systems are working. Keep in mind that 3PD, sometimes you'll get some of this testing done and it actually might all come back normal. That can happen with this diagnosis because it's a functional diagnosis, right, where the brain has restructured itself. But if you have some sort of a concurrent vestibular disorder that's going along with that, you might show abnormal testing with the vestibular testing. So I really like this diagram in a sense of like how we would treat 3PD. You'll see up here, like we talked about, you'll have that original dizziness trigger that'll be that onset of symptoms, whatever it might be. And what happens is that we will progress into this 3PD-like state. And they describe it as this brain hypersensitivity, where that brain is just really sensitive to a lot of stimulation. It's like if you think of a radio dial and you've dialed it up all the way, all these things that used to not make you symptomatic are now increasing those symptoms. What happens with this 3PD is we can treat it with medication, vestibular physical therapy, or psychological therapy. Now, when we have avoidance of neck movements, and that's when my patients come in here, we call very in block, where they turn like this. They don't have disassociation between head and neck movements, because when you increase that head movement, that causes more dizziness. What happens then is you start to get neck pain and headaches because those muscles are really, really tight. And that's something that we can address in the vestibular therapy. We also have these psychological things that are going on where we have anxiety and avoidance of going out. Fatigue starts to set in because our brain is kind of on overload trying to control those dizziness symptoms. A lot of my patients will report that, like by the end of the day, just feeling so wiped out. Disassociation here, what this is kind of a disconnect between the head and the body. Some people will describe it as like a floating sensation or a spaced out sensation. So physical therapy, and that's pretty much our bread and butter here. First things first is that we have to address if that initial onset of dizziness is still active. So say, for example, that initial onset was PPPD, where those crystals are loose. That's something that we would have to address in physical therapy. If it's vestibular migraines, which we know is also a common cause for 3PD, introducing a vestibular migraine diet to that. And this is a list of all the different exercises that we do here in physical therapy. If you're a patient here, you're probably fairly familiar with these. So the first one is called vestibular habituation exercises. And these are exercises to reduce dizziness through repeated exposure to a specific movement or visual stimuli that can cause an increase in dizziness. So what these exercises are essentially trying to do is reduce that noxious stimuli or response that you're having to a specific movement. So say, for example, I get dizziness when I bend down. If you gradually introduce that movement where I'm slowly starting to bend further and further down, your body desensitizes to it and it no longer feels that that's a noxious stimuli. It's the idea of, like, say, for example, I got my wedding ring on. You're so aware of what that feels like when you first put it on. But as the days progress, you no longer feel that ring anymore. Somatosensory reweighting exercises. So like we talked about, 3PD is fairly characterized as this visual dependency. So what we try and do with these exercises is actually promote the somatosensory system, the feeling of where our body is in space. So we do that by doing eyes closed exercises. And when I'm closing the eyes, I'm getting rid of that visual system, forcing that somatosensory system to kind of play its part and take up those balance systems. Gaze stabilization or VOR exercises. These are the ones where you're staring at an object and turning your head side to side. These are exercises that I generally don't start with for 3PD patients. And the reason for that is they're very visually stimulating and they can increase a lot of symptoms. But in general, they're trying to improve the ability of gaze with the head with the eyes while head is moving. So patients that would be appropriate for these exercises are patients that feel when they're turning their head that their visual system is bouncing or jumping. Visual desensitization exercises or optokinetic training. What these are trying to do is improve what's called visual vertigo, which is symptoms that are provoked or exacerbated by excessive or disorienting visual stimulation. Typically, my patients are going to report having increased symptoms when you're in supermarkets, driving, being in front of the computer, texting, because of all that visually enriched stimulation. These exercises are essentially like the habituation exercises, but for the visual system. So exercises to help reduce the sensitivity of being in these visually stimulating environments. And if you've been a patient here, the checkerboard is a common exercise that we do. Cervical manuals. So we perform these to help improve if somebody has neck stiffness from movement apprehension. When you have that movement apprehension, you generally will start to have headache type symptoms, and it can be helpful to help reduce stress as well. Some of the examples of manual techniques we do is like soft tissue mobilization, where we're kind of breaking up those knots. Joint mobilization is if you have any hypomobility in the joints. Stretching, and then facial manuals if you have any headache type symptoms. Another thing that we definitely go over is symptom management techniques. It's very important that we activity pace. So I always tell everybody, therapy here is not a no pain, no gain type of therapy. That's not how it works with the vestibular system, because that vestibular system can get overstimulated. And when it gets overstimulated, you might be down and out for a few days. And that's not what we want. We want to promote function. I really like the spoon theory, if anybody's heard of it. A blogger, in I believe 2003, created this theory to help kind of describe what it feels like to have chronic illness. And essentially what it is it's a metaphor or a visual representation to kind of report what it feels like when you have energy rationing or symptom intolerance. And if you think of all these different spoons as to all the activities that you have to get through for your day. So say, for example, getting up and taking a shower is one spoon. Eating breakfast is another spoon. At the end of the day, do you still have all your spoons, or are you completely spent? So for 3PD patients, it's really important in a sense of like you're pacing yourself throughout the day. You're not getting rid of all those spoons. Grounding techniques is something that we'll utilize if somebody's having an increase in dizziness symptoms. That can be deep breathing exercises. Sensory reweighting is when you're sitting and kind of focusing on body contact to help kind of tell the brain, hey, I'm not moving. Trigger identification is really important to help determine, okay, what sorts of things will amplify my symptoms? Is being in a visually complex environment going to increase my symptoms? Is doing too much physical activity going to send me over the edge? And then for those who have that concurrent vestibular migraine diagnosis, it is important to kind of learn about the migraine triggers. And if you were here at the last meeting, I know Joe went over a lot of those. I put this slide in because it's somewhat of a newer thing that's starting to come out with physical therapy. It's called vagus nerve stimulation. And what the vagus nerve is it's one of our cranial nerves. It's called the wandering nerve because it innervates so many different parts of the body that you can see in that picture there. And essentially what it does is it regulates the autonomic nervous system. And the autonomic nervous system is our involuntary physiological response to things. So our body automatically already breathes for us, controls our respiratory rate and our heart rate. And that's part of what the vagus nerve does. So when we have flight or fight response, which is our sympathetic nervous system, our body kind of goes on this overdrive. And with dizziness and anxiety, that body actually remains in this sympathetic nervous system upregulated position. And what the vagus nerve stimulation can help do is help activate the parasympathetic nervous system, which is the opposite, which helps kind of with that rest and digest. And if some of you follow us on Facebook or go on our website, Dr. Jerry Young actually just recently wrote a blog about the vagus nerve, so I highly recommend looking at it because he definitely goes into much more detail about the pathophysiology of it and how it can be helpful. But stimulating the vagus nerve we can do with like manual techniques, deep breathing. So benefits of physical therapy. They did a study in 2014 which identified that vestibular therapy can help reduce 60 to 80% symptoms and increase mobility and daily function for patients with 3PD. They suggested that VRT be continued for at least 3 to 6 months to receive maximum benefit, and I highly agree with that. It's not like BPPV where you can just fix it in 1 to 2 visits. We're trying to make changes and rewire that brain. So you do have to give it a little bit of time to adjust. And they also did find that VRT was helpful in reducing stress and anxiety in these patients. So cognitive behavioral therapy, this is going to be for somebody who specializes in psychology or a psychiatrist, but they did find that CBT was helpful in reprogramming the heightened attentiveness about dizziness and to help reduce anxiety symptoms in these patients. They also did recommend that CBT be performed in conjunction with other therapies such as medications or vestibular therapy. So medications, I'm a physical therapist, so I can't prescribe medications, but these would be given to you by your doctor. They found that SSRIs and SNRIs were the only beneficial medications for 3PD. So they found that primary symptoms were reduced by at least half in 60 to 70% of the patients. They found that there was only a 20% dropout rate due to medication intolerance. And they did feel that you had to take these medications for at least 1 year to minimize relapses. The other thing that they found was that benzodiazepines and vestibular suppressants, that's going to be like your over-the-counter Bonine or Dramamine or Meclizine, were not effective in treating 3PD. So I did just want to leave you off with some more resources about 3PD if you wanted to look up some things. Neuropt.org is a great website. It's actually geared a little bit more to clinicians, but they have some really great fact sheets on there, information about differential diagnosis. Vestibular.org I feel is a little bit more patient friendly. It's called the Vestibular Disorders Association, or often referred to as VITA. They have a lot of information about vestibular disorders and also a healthcare directory. So if you're looking for a doctor or a physical therapist or somebody who specializes specifically in vestibular, this is where you can look. The dizzycook.com I think is a great website. She is actually a blogger who has vestibular migraines, and she actually has a lot of podcasts where she talks to clinicians who are vestibular specialists. She has a cookbook for anybody who's on the vestibular migraine diet. She has really great recipes that look really amazing. And then there are some other apps on there. The Juva Biofeedback app is helpful in kind of deep breathing, and there's meditation apps such as Calm and Headspace. I know on my Apple Watch it always tells me to do that mindful meditation that I never do but should. And then last one is a Migraine Buddy, and that's an app that if you have migraine triggers or vestibular migraines, you can go on there and track some of your triggers on there. So I know we're going to meet for the support group in a little bit, but does anybody have any questions about anything right now? Yes.
Does the sleep patterns play any role in it?
Yeah, definitely. Sleep is always going to be important for honestly any type of diagnosis. I always tell my patients, like, it's very important to get good sleep and to have consistent sleep, right? We have our circadian rhythm, so I always recommend like picking a specific bedtime that you want to go down, picking a time that you want to wake up. Sometimes people, like when they nap and things like that, they'll feel even worse, and that's because you've messed a little bit with that sleep cycle.
You have this throughout your life, like episodes that go on for a very amount of time, months, and then go away when the stress goes away, usually induced by stress or anxiety, and then it just totally goes away, and then 7 years later it comes back.
Sorry, I kind of heard you. Was it about?
You have episodes of this throughout your lifetime. I personally have had about 7. I'm on my 7th, but I can go for 7 years being okay, and then it comes back. And it could take months, or who knows, maybe it'll never go away.
Yeah, so 3PD is going to be characterized as kind of this constant dizziness. So it's hard in a sense of like, I don't know if like your initial triggers are caused by maybe some different vestibular diagnosis or not.
Anxiety and stress.
Yeah, anxiety and stress is a huge factor, not only for 3PD, but also a lot of other vestibular diagnoses as well.
I was wondering, you've probably heard of, I think it's Joey Remini.
Yeah.
Okay, and she's really into neuroplasticity. I want to get her book for sure. And it sounds like it makes sense. I'm just in the process now of researching that a little more, but I wondered if you had any input or wanted to talk about that at all.
Yeah, that's a great point. I should have included that. Joey Remini is a audiologist, I think, from Australia, and she developed or wrote a book called Rock Steady. I think it's a great book for patients to kind of understand a little bit more about the neuroplasticity. She gives a lot of helpful hints and things like that on how to kind of help control dizziness as well. So Rock Steady if you're interested in the book.
Can you explain again in layman's terms about neuroplasticity?
Yeah, it's a hard concept. Yeah, I think of it more as like, you know, when we learn something new, right, our brain, what it does is we have all these neurons, and that's like how our brain functions and works. And it sends messages to the other neurons to say, hey, okay, I'm gonna learn this specific movement, right? And that's what we call as adaptation, where we make these changes within the brain. And that's how, like we talked about, okay, when you get on that bike, it's something that you don't have to remember or like consciously think about, because our brain has now made this neural connection where we don't need to like think about things anymore. We just do it. It's like muscle memory essentially. So essentially what neuroplasticity is our ability for our brain to change and adapt and, you know, get better and improve. But you can have maladaptation where things kind of go a little bit haywire. If you think of it as kind of like a computer where you have your hardware and you also have your software, right? I'm not super into what computers do, but I think the hardware is like essentially how things function or work, whereas that software is, okay, let me put everything together and make it function. The hardware works, right? The brain works. It's the software that's not working or it's malfunctioning, right? And so that's essentially what neuroplasticity is the wiring of the brain. Structurally, everything's okay. It's the wiring itself. Does that make sense? Yes. Okay.
So, I know there are quite a few supplements that are useful for migraine, such as magnesium part of it. Are any of these in particular helpful for 3PD, or are they all sort of possibly helpful for any given individual? Or?
Yeah, that's a good question. Supplement usage obviously is going to come from your doctor because we don't necessarily prescribe medications. But yes, supplements have been found in research to be helpful for dizziness symptoms, not only for 3PD, but various other vestibular diagnoses.
Are there any things that are not specific for migraine, but they're more specific for dizziness? Like, to me, ginger sometimes helps me because sometimes I get nauseous.
Yeah, that's more for like nausea symptoms.
And sometimes the nauseousness will go away and the dizziness will feel better too.
Yeah, I mean, there's different supplements that they've found, like the B complex vitamins, CoQ10s, riboflavins, but I would discuss those with your doctor before you started to take any type of supplements. I think we're gonna take a break. Oh,
So there's some questions online.
Just kidding.
Oh, by the way, we're gonna have these slides available if you want them. Just make sure you give us your email on the way out, and then we'll send it all together on Monday. Okay, so I saw a lot of you guys taking pictures. We'll have these available to you, so please just write your email, and then we'll send it to you. A question from someone online: can 3PD go away permanently, or is it chronic?
Yeah, that's a great question. I like to think of 3PD as a spectrum, where everybody's gonna kind of differ in terms of their intensity or their severity of symptoms. With it being on this spectrum, can be challenging to say specifically how well things are gonna improve like initially versus like later. The unfortunate thing too with 3PD is it's something that, you know, people won't end up getting treatment for until it's already been going on for like a few years. So the chronicity of things is gonna make it a little bit more challenging. In terms of recovery, you can always recover, but you're gonna have these different factors like chronicity and severity that are gonna play a part. So you can't really put a timeline in terms of how well you're gonna, or how quickly you can recover from 3PD.
Do any of the PTs have any inputs on that? For me, I did see, I've treated a lot of patients with 3PD, and yes, I've seen many of our patients improve completely. And also we've seen patients that take a long time to recover. So everyone's really different in how they respond, but it really is, what I've seen is if you had 3PD for 3, 4, 5 years before you start therapy or start treatment for it, then it takes a little bit longer to get better from it because your brain solidifies for that. But when they had it for 3 months, which is the criteria, it's a lot shorter to kind of get away from that. Does that make sense? So the neuroplasticity, there's a good neuroplasticity of learning how to, get away from that. And then there's the other part where you're just solidifying the 3PD from getting worse. So that's why treatment, getting help is really, really important. Faster the better, earlier the better.
So the little drug chart you showed before, so those top drugs, they're all antidepressants, correct?
Yeah, they're commonly going to be like antidepressants, anti-seizure medications.
I can't use those. And it's funny because you said meclizine doesn't help. It helps me, but I guess we can talk about that.
Yeah, long-term usage of meclizine is generally not recommended. What meclizine does is it's a vestibular suppressant. So what it does is it actually suppresses the response of the vestibular system. So it's kind of almost like a Band-Aid, where it might help like initially, but long-term effects, you're gonna have changes with the use of the vestibular system. But you can discuss with your doctor if there's any other medications.
I only take it when I know, because driving does it, right? So movement. So if I'm gonna drive more, I'm a sales guy, I drive everywhere. So if I'm gonna drive more than 100 miles in a day, that's the only time I take it. I preload it in the morning and it gets me through the day. I don't take it every day.
Yeah, and that should be fine. We just don't want like chronic use of meclizine. I'll first, sorry.
I hear you recommending physical therapy, but you're talking about a year's worth or 6 months worth. Is that kind of the norm?
Yeah, so kind of like we talked about, vestibular physical therapy research has found is helpful, but it's something that you kind of have to be somewhat consistent with, where, some people will come in thinking like, oh, okay, it's just my crystal's loose, it's gonna fix in like one visit and I'll be completely fine. Where that's not the case with 3PD, because we're trying to make, restructure the brain, rewire that brain. It's something that's not going to happen overnight, and I do recommend coming, my patients come here, like at least start with like 6 to 8 weeks of therapy and see how you respond first before you give up. Oh, yep, sorry.
I just wanted to share that I've been living with this since a very bad car accident it'll be 7 years next month. And I was getting pretty depressed over it. The ear, nose, and throat guy recommended I come here, and this is after he said do Epley maneuver and stuff and come back to me if it doesn't work. Well, I was so depressed that I didn't go back for a year, and that is when he told me about Dr. Cho at House Ear, who used to come down to Orange County every Friday. And he's the one, and I had the whole ENG diagnostic test. They said I had ear crystals on both sides, which is very unusual. And he, in like 2 minutes in his office, just testing me physically, he said, you were misdiagnosed, you have triple PD. And I said, what's that? And then I found out, and I could never identify it with the other PPPD symptoms, but I finally felt so vindicated, because you kind of feel like you're crazy. And I've only, in 7 years, only by happenstance met one other person with this disorder, and with vestibular migraines. Dr. Cho suggested that I take Effexor, which is an antidepressant, and I was a little about that. And I think often they start with only a half dose. It's would you have the therapeutic dosage if one were clinically depressed. And it hasn't seemed to help me, quite honestly, with the PPPD, but at least I'm not quite as depressed about it anymore. I just wanted to share that if anybody has.
Yeah, thank you so much for sharing. I completely agree in a sense of, I get patients that, it takes like 5-6 doctors before they find us. And they were misdiagnosed and they were told different things, where, just finally getting that 3PD diagnosis, honestly, like, decreases a lot of the anxiety. And when you find a clinician or somebody that understands truly what your symptoms are, it makes a huge difference. And yeah, what you were talking about with Dr. Cho is, he does a lot of microdosing, which I think can sometimes be helpful for patients in a sense of like, I do find that a lot of vestibular patients are just very hypersensitive to begin with, and that includes with medications. But yeah, for medications and things like that, chat with your doctors about that. But thank you so much for sharing.
We have another question. They're asking, how does ice pack help on the neck for 3PD and dizziness?
Yeah, that's a great question. We utilize ice packs a lot here in therapy. If you're coming to therapy, I'm sure you know we always end with an ice pack after vestibular treatments. Ice in general is known to be helpful for dizziness-like symptoms and for nausea symptoms. When we put the ice pack around the neck, we're actually trying to target where the vagus nerve is as well. And ice in general is going to help kind of reduce that response of dizziness versus like heat. Usually people won't respond to the heat. So if you're doing any activities, like say you're driving and you feel really dizzy, throw an ice pack on. It'll help a lot. Yes?
Have you had any patients benefit from the gamma core vagal nerve stimulation device?
Yeah, that's a great question. So in terms of vagus nerve, they've recently come out with this device called the gamma core that Martin brought up. What it is they can stimulate the vagus nerve, kind of like electrical stimulation, if you're familiar with that, on parts of the neck. It is fairly newer, so I'll be honest, I only know one patient that's used it so far, because I think it is a little bit expensive, and you can rent it, but it's still a little bit expensive to do. I'll be honest, she didn't notice any like truly significant changes in her symptoms, but that's a patient sample size of 1, so I can't really, I don't know if anybody else has a patient that has gamma core. No.
I just have one, but I think, again, it's something that I think for me as a therapist, I'm always trying to find strategies where you guys don't have to buy like expensive things. You're trying to use tools. We're trying to use as many tools that you guys have available without having to buy all this fancy equipment. So like Jen said earlier, the vagus nerve treatments are kind of this, honestly within the past year, I feel like just coming out. So I have a patient on one who I think it is helpful, but it's not like this drastic thing. And that's where I think for 3PD patients, a lot of times I always say we have to be very open to various treatments. It's not just physical therapy that's gonna help. It's not just a medication that's gonna solve things. A lot of times it's looking at big picture, looking at the entire body, the entire lifestyle. So, I think I wouldn't solely depend on that as a treatment to solve things. It's usually in combination with other things that is gonna give you the maximum benefit.
Do you still recommend that, what is it called, the heavy blanket, what is it?
Oh, the weighted blanket?
Yeah, weighted blanket.
Yes, so I've talked to some of my patients a little bit about using weighted blankets, if anybody's familiar with those. You can get them at Target, Costco, but it's essentially a blanket with weights throughout it. And so for patients that feel a lot of like rocking, swaying type sensations, I'll ask them to put that weighted blanket on, and it just adds a little bit more of that somatosensory input or that proprioceptive input. So in general, a lot of people will feel a little bit of a reduction in the dizziness. And those blankets were originally developed for people with PTSD, so helps a little bit with anxiety as well.
Yeah.
Another question, have any of your patients used the alley lamp for 3PD?
Yes, we have an alley lamp here. What the alley lamp is this neurologist developed a green light. They found that, it does the opposite of blue light, which is that aggravating light, the fluorescent lighting that usually everybody will feel dizzy with. Kelly has one up here if you want to look at it. But they found that green light kind of does the opposite of that. So it helps to reduce some of those anxiety-like symptoms. Generally with use of the alley lamp, you want to be in a dark room. So no external lights, no being on your computer. And it's supposed to help with migraine symptoms, but I have found that it's helpful for treating patients with 3PD as well. If you're a patient here at the clinic and you haven't used this and you want to try it, just let us know.
Any other questions before we go on a break? Yes.
So if somebody has vestibular migraines as well as 3PD, would treatment vary? Like, are there different exercises that would be done? Or I know I've read that treating vestibular migraines first is important versus treating the 3PD.
Yeah, so with 3PD, we do see a lot of patients that have a concurrent diagnosis of vestibular migraines, with that potentially being the onset or the trigger of 3PD. With vestibular migraine diagnoses, there are other things that we need to address. If you were here at the last support group meeting where Joe gave the presentation on vestibular migraines, you do kind of have to address that migraine component. So we know that with migraines, there are specific triggers that can aggravate migraines. Certain dietary things that we might need to change. That's something that we kind of co-treat with the 3PD-like symptoms. But in terms of like exercises and things like that, they're generally going to be somewhat similar.
Okay, so this ends the workshop part of our morning today. We'll take a 5-minute break, and for those of you who has to go home, you guys feel free to do that. But for those of you who want to join the support groups that part of this group, please come back in 5 minutes. Yeah, so one of the reasons why we started these Saturdays workshops and support group meetings is I had a patient, just like someone who commented earlier too, he was saying, I've never met anyone else with 3PD before. I only met maybe one other person, and I would like to connect. And that's why we started these meetings, and we wanted to make sure these meetings were respectful, right, of each other's, comments and stories. But also we needed to make sure that there's a professional that's guiding these meetings, because we want, the information that's being said to be correct, right? The most up-to-date information. So we didn't take that lightly, and we wanted to do these meetings. So far, this is our 3rd meeting, and I feel like it's going really, really well. And it's been helpful for our patients. But, one of the reasons why we started this is because we want to advocate physical therapy too, right? We want to let our patients know, or patients that don't know us, to know, there is help other than just medication or other things. And, we as physical therapists could really help. So this is our way, Ascend Physical Therapy's way of giving back to our patients and our community. This is not, this is a Saturday where I have to ask our doctors of physical therapy to come and speak to you guys, and they have families, and it is difficult. That's why we can't do it as often. But the only thing we ask is that you guys could, if you guys have friends or family members or doctors that don't know about dizziness or vertigo, or where to get help, if you could let them know about our clinic and just say, there's help out there that could really make a difference, that would really help us, because our goal as Ascend Physical Therapy is to be the best vestibular therapy clinic in Orange County. Currently we have 3 locations. We have one in Buena Park, one here, and one in Laguna Woods for South Orange County. So we're trying to, do our best to get our clinic known in the Orange County Road. We've been here for 20 years and we're still growing, so please help us. For the support group meeting part, we'll just start with questions again, if you guys have any questions. I had one question just to start us off on the chat room.
Sorry, can I?
Yeah.
Because there's still people that are joining us through Zoom. I'm like, what do you even call that? Virtually, thank you. I'm like, oh my gosh, what's that word? So if you guys have questions or if you want to respond, just raise your hand. Joe and I will probably be passing around the mic. That's the only way that they're able to hear those questions too.
I guess let's first start off is, how many of you guys have 3PD? Were you diagnosed with it? Have you been diagnosed with 3PD by a doctor? Okay. Yeah, so there's, how did you guys get to that diagnosis? Because it is a really, not a lot of people know about it, so how did you guys find out about it? Dr. Cho?
How many of you are Dr. Cho patients that were diagnosed with 3PD? So it's pretty much, I think most of the patients that raised their hand that were diagnosed were probably by Dr. Cho. He was at the House Ear Clinic and recently transitioned to Cedars-Sinai. You will frequently hear us refer to him a lot because I do feel like he is one of those leading doctors that really understands these kind of more up and coming diagnoses and how to treat them without, a surgical approach or you're dizzy, you'll be fine type of a thing. So he used to be at House Ear Clinic where he would come to they were based out of downtown LA, and then now they also have like an Orange location that's fairly close to us. But at the start of the new year, I think that's when he was at Cedars-Sinai, so he's only based in LA now. However, I don't know if you guys that are still seeing him, he does do telehealth appointments, so that has kind of been a saving grace for, I think, a lot of the patients that are still based out of Orange County. They're still able to do telehealth. I was gonna, yeah, thank you.
So I have a question for you guys. So earlier Jen said, 3PD, you have an initial dizziness or vertigo event that happens, and then after having those symptoms for over 3 months, that's when you start to develop more 3PD symptoms as well. I'd like to ask you guys, what was your initial event that caused the vertigo? Was it PPPD, migraines, or any other different types of dizziness? If anyone who'd like to share.
For me, it was both. I had a back-to-back, and then for me, it was both. I had a back-to-back. It was a BPPD first, and then both Kelly and Jen helped me through that. And then the following week, it was like a reset. I had another vestibular event, vertigo event that happened. And on that one, it was now the migraine-associated vertigo. So from then on, my crystals were cleared, it was back on, but now is now the rocking and swaying sensation that has lasted now since then.
Anyone else would like to share?
I'm not exactly sure what caused mine. I just remember a few months ago just all of a sudden having that rocking swaying sensation. So I feel like maybe there's some people where it's not necessarily a migraine or BPPD, because I don't know exactly what caused the onset.
I had an acoustic neuroma in 2010 and originally came here when Teresa England was still here. And I felt like I had accomplished my goal. That was 12 years ago. In the last year, I've noticed that I don't know if it's age related or what, but I have a dizziness now that's different than what I had post-surgically. And so I'm interested to learn whatever I can.
As I mentioned earlier, mine was definitely caused from a car accident. And even in the hospital, I was broken stem to stern. I was on a lot of medication for 3 weeks, and then took a long time to rehab. And I would complain to a couple of nurses that I had dizziness, and they would say, "Oh, honey, you're on so much medication. It's a side effect from the drugs, probably." But I knew my body, and I knew that it wasn't. And I was afraid to speak up to doctors about it because my license was suspended, and that was a whole other issue. And I wanted to ask maybe Jen's input, Joe's, whomever Kelly's, There is a personality type associated with this. It tends to occur more in women, and I've done right away as much research as I could, and it tends to be introverted people who have some degree of anxiety, and at the risk of seeming like you're neurotic, I have to say that that typifies me more than not. And so my symptoms are exacerbated immediately upon pleasant excitement, physical or emotional stress. And if I calm myself, they can dissipate momentarily a little bit too. Is there a personality, is there a right brainness aspect of this? Like, I'm very left brain deficient, I'm very creative and very visual, extremely visual. I'm an interior designer, and I'm wondering if that's how, I was the kind of person who, if the escalator got stuck, it would freak me out because I couldn't look down. I had to look forward and just pretend they were stairs because it was so ingrained in me that they should be moving, and so I trip over my own feet. Anyway, that was my question.
That's a great question.
Okay. Sorry to take some.
We'll take turns answering our.
Yeah, I think, yes, we know that for 3PD, there is very much a psych component to things. It is much more common if you do, I think Jen touched on that during her presentation. So patients that have a history of anxiety, depression, kind of panic attacks, nervousness, that type of thing. I think you will naturally see different tendencies. Like I've always, a lot of times patients will say, like, I've always been motion sensitive. Like, I'm the type of person that my husband will pull into a parking spot and I'm like, oh, really? And he's like, what? Like, I just turned. Like, I just naturally have more sensitivity to that. Does that predispose you? I think that there can be some amount of kind of contributing factors. If you have a job where you're so visually, dependent on that, then yes, you can kind of develop those visual tendencies just because that brain is already geared towards relying and overusing that system. You'll also see it just for, patients where, yes, for jobs or if they're on computers a lot. We see it actually for patients that have gone through other therapy. It's really common in the vestibular world that you're gonna end up doing a lot of these like visual exercises. So they sit you in front of a computer and they have you like follow this ball back and forth, which that can be helpful for some patients. What we have found is you really do have to have a better balance of the therapy. You can't just be working that visual system because you're also in turn working that brain and wiring it to say, oh, okay, like I have to use my vision, I have to use my vision. But there's always going to be environments where that vision is complicated. So things like looking at an escalator, driving, walking outside, walking in doctor's offices where there's different like visual patterns. Even here for our flooring, sometimes patients are like, oh, like this is hard to walk in. So I think it's really, if you have those visual tendencies, it's important for us to kind of understand that so that way we can give you exercises to combat that. I'm pretty big on, I mentioned earlier, you really do have to think of it as treatment as the entire person, not just the physical aspect, not just the inner ear. I feel like all of us are very good at reading our patients and kind of starting to get a feel for, okay, do they have this underlying anxiety? Do they have this kind of tendency to perseverate on their symptoms? Do they have kind of this underlying depression? And so that's where, a lot of times we are open with you guys of, okay, do you recognize this? If it's something outside of the scope of what we can handle or recommend, then it's trying to get you guys into, either doing the cognitive behavioral therapy or seeing a psychologist or, working with those experts in their field versus, us as physical therapists.
So there is some recent research that they've done on patients with just general public, where they did questionnaires and things like that that were 3PD-like questionnaires. And what they found was that actually people already were presenting with 3PD-like symptoms before they even had that initial onset of that vestibular crisis or psychological onset or whatever that onset might have been. So I do feel like what you talked about in a sense is that we are kind of already predisposed a little bit in terms of like our personality or, ourselves, and that when you have that onset, that's kind of when those 3PD-like symptoms present themselves.
Are you suggesting that your brain hanging on to something that was always true but is no longer true is predisposes you, like the escalator?
Yeah, so kind of like what Kelly said, where like people were already like sensitive to motion to begin with. And then they've done research after that when people have had 3PD diagnoses, where they did what's called fMRIs, where they look at the function of the brain, and they see that the visual cortex, the portion that's responsible for our vision, is actually more active compared to other parts of our brain. So it is definitely a structural involvement with the brain that's going on as well, where now we're actively overusing that visual portion of the brain, not using the brain as one whole entity, essentially.
Along that though, like I tell patients, you are who you are. That's not for like, I'm a perfectionist. Like no one's gonna change that. You have been who you are for the past however many years, right? So it's not us to be like, oh, there's something wrong, we need to change that. It's trying to manage those symptoms and those stressors and those, if you're able to recognize, okay, like I have had a really stressful day, then I need to be able to self-reflect and know that that's a big trigger. And what are tools in my pocket now to be able to manage that? Okay, I have had a lot of visual stimulation, so what are tools that I can use to kind of regress from all of that visual stimuli? But I think that that's what's been very challenging for this diagnosis is many patients are meant to feel like I'm crazy, like I am making up these things in my head. And day one, I'm like, no, you are not alone. You are feeling these symptoms. We might not be able to look at you and tell that you're having these symptoms, but I know you guys are feeling that internally. So it's acknowledging that you have them. It's not to say that there's something wrong with you. It's just we need to work on ways to better process it and to manage those triggers.
I just want to add, this is where the art of physical therapy is from. So like we as vestibular therapists, we've seen so many different personality types come in here. We've seen so many patients, the way they cope with their dizziness, and we've treated it so many times that when we meet a patient, we know what pace we have to take them through therapy. It's not, you can't just look at a textbook and just do these exercises and just, have our patients do it at home. We have to be able to see when is it the right time to give them these exercises? When is it too soon? When do we start to introduce, VOR exercise or habituation exercises? And it's because every patient's, their personality is so different and the way they handle the dizziness is so different. For your question about like personalities, I've seen so many different types of patients where one is like really easygoing. It's like, oh, I'm dizzy. I just feel it, sometimes. And he's doesn't care too much about it, but he's like, I just feel it. So I'm just here. Doesn't care too much about it. And then I have the other patients where, their ears are glued to their shoulders and they're so afraid to move their head. It took them, it was courageous for them to leave their home. And when they come into us, they're really apprehensive, thinking like, what are you going to make me do? What are you going to do that is going to help me? And the first thing they say is like, I haven't moved my head because every time I do, I really feel dizzy. Or they got these, recommendations from doctors saying, don't move your head then. If you're dizzy, don't move your head. It'll go away on its own, right? And so with that information, they, for 3 months or more, just avoided laying flat or avoided, turning their head or going to markets. They just avoided a lot of things. And, you know, everyone's so different, their personalities are different, so the way they handle the dizziness is different. And so their anxiety levels are different. Their response to this is so different. So as physical therapists, like our job is to figure out like how fast what exercise could we give them and how early could we give them? You know, how do we get them better without exacerbating their symptoms? What is their threshold for activity? What could they do before they're over the edge? The spoon example, teaching them all of that, you know? So super important. And I do feel like personalities types do have a factor in the amount of patients that have 3PD. It's how you cope with anxiety is a big one.
Is there any difference in the treatment focus between your Laguna Hills facility and here? Because I live in South County, so you know, obviously driving up here is something that I could do.
So that's a great question. All 3 clinics, we do specialize in vestibular therapy. This is the first clinic that started 20 years ago, and we branched out of here. So a lot of our training, you know, we try to do things very similar between therapists, but of course, between therapists, we do have a little bit different approaches. But yeah, Laguna Woods could definitely help. We had the correct equipment there. We had the correct equipment there too. We had the goggles, we had the posturography machine, and the therapists are from here. The director in Laguna Woods was a therapist here for 3 to 4 years before he became director, and he's working there now.
That was the answer I was looking for.
Yeah.
You may have said that focuses more on orthopedic athletic injuries, and here's where the balance is. That would answer my question.
Yeah, no, we're all balanced clinics. I would say Buena Park has the most ortho patients than the other 2, but Laguna Woods and here we have a lot of dizzy vertigo patients.
Thank you.
Things changed since 2007, what you do, what you test, or machines you have, or, because I was in 2007, and there was a machine that was measuring and stuff, and we did a printout.
It's probably in this room back here, so we can open it up. Yeah, I mean, we still have some of that equipment. I've always felt that, I had a patient in another state and I just met with her and we were trying to come up with, okay, where do you go? Because she obviously can't be coming here. And I said, you know, if you find a place that is really truly specialized in balance and vestibular, they're gonna have certain equipment. Like they need to be having those goggles. There is usually some type of a machine that they can do objective balance testing. So I think the machine you're talking about is in that room. So we still use that equipment, which should be used in every exam. I think the techniques, I think the diagnoses, I think that all just gradually changes. I've been here 10 years and I can tell you that there's definitely growth that happens. I mean, we didn't even have this diagnosis, 3PD exists 10 years ago, really. So in that sense, there's a lot of different tools that come out, like the vagus nerve stuff is newer, and those gamma core and the alloy light. So I think in that sense, there's a lot of other than just the equipment and exercises, there's all these other side tools that have been developed and that we try and incorporate and use within the therapy.
I'd like to share the question that you asked during the break. I think it'd be great for everybody. So I'll just ask to Jen to see her answer.
Let's just
I gave my answer. It's a good question. He said, walking into the supermarket, it could be a trigger, but can't that also be a treatment?
That's a very good question.
It is, good job.
Yes, and that's why I kind of always have to tell my patients, like, you need to understand your body and your tolerance levels. So generally, like, if somebody's telling me, hey, I have dizziness going into a grocery store, I'm asking all these questions. Well, how long are you in the grocery store? Did you drive yourself to the grocery store? What are you doing in the grocery store? Just to get kind of a baseline in a sense of, okay, what can they tolerate? And in general, I'm like, okay, usually grocery stores are gonna be very visually stimulating for people because not only do you have bright lights, you have everything on the shelves, sometimes they have patterns on the floor. So it's
You have to avoid other carts.
Yeah.
Yes.
Yeah.
Adaptation.
Yeah, so there's a lot going on in grocery stores where when we start to do exercises and things like that, we do what's called graded exposure, where you initially start like gently with things. And when we're pacing exercises, I always say like you want a little bit of dizziness. You don't want it to be too overstimulating. So if somebody's leaving the clinic and they're saying, hey, I came back and I was dizzy for 2 days, then in my mind I'm thinking, wow, that was way too much. Right? You should be feeling somewhat okay when you're leaving this clinic. So when we introduce things like that, I'll say like, hey, let's practice just doing like head turning inside first. And then let's practice doing head turning outside. And then let's just practice going into the store for a few minutes, grab one thing and come back out. And then let's practice doing, okay, let's grab a couple things. So yes, it is gonna be a provoking thing, but you're going to expose yourself gently to that, provoking task or whatever it might be, so that it's not so much of a noxious stimuli anymore. Does that make sense?
To add to that, a lot of times you don't want prolonged avoidance. So when it comes to the inner ear, if patients come to me and I always say, oh, it's like Frankenstein, like they're like moving like this. I'm like, oh, okay, like they are very apprehensive with movement. They probably don't want to move because it triggers their their symptoms. So it's not just movement based, it can be visually triggered. So it is that graded exposure because for me as a therapist, I'm always like, what's normal? It's normal to be able to walk outside. It's normal to be able to walk in a grocery store. So I'm always like, what are your normal activities? And if that's something that you're limited in, like the therapists need to know so we can come up with exercises that can help get you to those functional goals. But yeah, we never want long-term avoidance. The way I usually will explain that like graded stimulation is, it's just like if you go to the gym and you start working out, your muscles feel sore. But that soreness is actually a good thing. It means that you're gonna get stronger, your muscles heal from that, and eventually that weight that you were lifting becomes really easy. And then you can add on more weight. And then you get a little bit sore again, but then once you get used to that, then you can add on more weight. So it's that in a nutshell, but just with like functional activities. So grocery stores are super, super commonly a trigger if you really highly rely on your vision. That's what all of that marketing is for. It's to distract, not to distract. It's actually to grab your visual attention. So if you have that lining the aisles, but there's different strategies that you can use. So I do just want to go over that very briefly as far as if you are going in visual environments. Something like a grocery store, I am like, make sure you have a cart because that support is very helpful. And also just trying to, if you get overwhelmed with things, it's like really focusing on, okay, my hands are on like the cart that I can control. Hopefully you're going into a store that is a little bit more familiar for you. So okay, you can plan ahead. Okay, I need to get this, this, and this. I know where they're at, so you're not just kind of like going down all the aisles. You can kind of grab it and go. A little bit of pre-planning in a sense of, do I want to go to Costco on a Saturday afternoon? No, not really. That's probably not where I would want you to start when you're doing that. So times of days where it can be a little bit less crowded and less anxiety. But also it's grounding yourself once you leave. So I'm a big fan of, if you've driven there and you feel symptomatic, you ground yourself before you enter the store. You ground yourself when you get out of the store. So you're not just escalating your symptoms to where you hit these huge thresholds that are so hard to come down from. you're escalating a little bit and then you're giving yourself a little bit of break so that you can tolerate a little bit more activity, and then you give yourself a little break, and then you can tolerate a little bit more activity. That's where all the magic happens in your brain. If you just go and crash and burn, your brain just shuts down and is like, I don't know what's happening anymore. I don't want to deal with this. And you're very symptomatic, usually for longer periods of time. So that pacing is very important for you guys, especially in the early stages of the therapy. I know someone had a question.
You just answered it. I often close my eyes and just take like a deep breath and just kind of bring myself down a little bit before I continue. So
Your visor too is actually something I will recommend in the like early phases, is if you have a visor or a hat, it actually somewhat can take away a little bit of your visual field, especially if you're sensitive to, these aren't fluorescent lights, these are LED, but in the grocery store, I think a lot of times they're still LED, and that can be really stimulating. So, but that is something that like I usually try and tell my patients in the beginning, wearing like a hat, but it is something that we want to like gradually
that was what I was gonna ask.
gradually take away from.
I just want to share another analogy. This week I was trying to learn how to swim better. So I was watching YouTube and getting tips. And then one of the things that the YouTube video was sharing about was, part of like the difficult part about swimming is when people hold their breath underwater, that's when their anxiety starts to creep in, right? So what they said for in the beginning when you're trying to learn how to swim better is first try to manage your anxiety. So they were giving tips where put your head underwater for 5 seconds and then come up. Now for 10 seconds and come up. 15 seconds, 30 seconds, 1 minute, right? And if you hold it for a minute, right? And so are you able to habituate to the feeling of holding your breath underwater and managing your anxiety levels? And so grading exposure, that's another good example of learning how to swim. Grading exposure to markets and visual stimuli works the same way. It's when we go into these markets and our anxiety levels start to just creep up all of a sudden, and then it goes past our threshold, that's when we are in trouble. But another example I want to give is I have patients that, they're afraid, they have a wedding coming up, their son's wedding, and this was a month ago, and she was afraid that she was going to be dizzy during the wedding. There's music, a lot of dancing, a lot of lights and stuff like that. But for her, she came back and she was like, oh my gosh, Joe, I did a really good job. And I was like, what happened? She was like, I was just so busy. Like, I was so busy that I forgot about my dizziness. She just didn't pay attention to her dizziness because she was so preoccupied with everything else that she just forgot about the anxiety part. And so this is where, for her, yes, there was a lot of visual stimuli and everything else, but she didn't crash and burn. But what was helpful for her to understand at that moment was, hey, I could do this. If I'm able to forget about it and be able to control my dizziness by, just trying to expose myself to, things that I used to do, going back to doing the things that she loves. That was really helpful for her. But yes, we want to be careful about, exposing ourselves to environments that might make us go over the edge. But for her, it was important for her to understand that those small wins, hey, if I can make 1 day, I can make that 2 days, I can make that 3 days, I can make that a week, I can make that a month, hopefully a year, hopefully I'm better from this. The recovery that I've seen from my patients with 3PD is they just say, all of a sudden I just stopped thinking about it. It didn't come to my mind as often. Like I just stopped thinking about it as much as I used to. And I was like, dude, that's a win. Like for you to not be so obsessed and, thinking about that visual stimuli, you getting away from that means you're getting better. If you're thinking about it less, that means you're getting better. And I tell my patients every time, you have to recognize the small wins. If you cannot recognize even the smallest wins of going into the market and out without being busy, if you can't recognize that, then you're not gonna get better. You have to celebrate those wins. You have to celebrate, you have to be like, yes, I was able to do that. And you're kind of telling your brains like, oh, I'm able to get better, and that's how you do get better. Does that make sense? If you can't celebrate and acknowledge those wins, that's where the PTs, our job is to be like, hey, you were able to do that. And we're trying to get them to be educated and learn, hey, look, that's what you're able to do because you got better. Like, we have to kind of share that with the patient because they don't always recognize those wins. But every small win is really, really important.
Usually the vestibular therapy it's slower. If you've ever gone to therapy for like orthopedics, you know, and that's how Jen was saying, I know it can somewhat feel daunting of like, what? I have to go to therapy for the next like 3 to 6 months or even more. If you guys are okay with sharing, those that have come to therapy, raise your hand if you've gone longer than 3 months with us, longer than 6 months with us, longer than a year with us. So it's not a super quick, spontaneous thing. I usually tell patients it's not black and white. You didn't have all of a sudden you're just because you're coming to see me, you don't have symptoms anymore. So the mindset I usually try and tell you guys is it's a marathon, not a sprint, right? And that's also important for you guys to understand because it's very common. Most of my patients know I will draw you a graph, that it's also not this straightforward, every day is gonna be a better day. I think that's what's hard with vestibular therapy too, is sometimes you're like, hey, I've been doing better. And then all of a sudden it's like, oh my gosh, what happened? I'm having like a horrible day or like a horrible week. That can happen. But for me, when I have patients that are like, hey, I had a good day, I'm like, great. Your brain and your body know how to get you there. It's likely not going to keep you there 100% of the time. But now your body knows how to respond and it knows how to process that information. That is going to happen more. That is going to last longer. And with time, it will be more and more better days and less harder days, right? So I think that's very important for you guys to understand that recovery. But yeah, in my mind, when I treat you guys, it's much more like it's a marathon.
I think it is really frustrating because for me, you know, I might think I'm doing pretty well for a week or whatever, and then something else happens, and because to use the analogy that's been given, you know, every time you go into the grocery store, it's not the same thing. You know, you might have a different list, might be a different time of day, it might be more crowded or less crowded, and you might do fine one day, and then you're thinking, oh wow, yeah, I can do this, and then you go in and you get clobbered, like, oh my god, I have to get out of here. I'm freaking out. So I think that's one of the frustrating things. So, you know, it's not linear, and it's hard to know, okay, I've reached this point, and this is always going to be okay for now. I'm always going to be able to do this. And there's just so many, you know, varieties of living that's sort of impossible. So it's sort of like you have to be on your guard every minute, like, okay, what could go wrong today? So, and that's stress producing, which of course makes everything else. But anyway, it's just my experience. 5 years I've been here.
I'm really good. But then I've like been having these relapses, and I found even before that now I'm even more triggered by noise. So like I have tons of plumerias and with all this heat, and I'm not supposed to, but I've been watering like crazy. And that's the other thing. So the spraying of the water and the turning and then the noise and everything else. And then all of a sudden I'm like, oh my God, I gotta go sit down. Like I feel like crap, I don't feel good. And then same with the grocery store. So I saw your email to me and I was like, thank God, because I need a refresher. And also I love going to concerts, so I just went to one. And that's the other thing is like, okay, now I gotta wear earplugs, which I should have anyways, but And then all the strobing lights and the drum in my chest, and so it's like all this stimulation is like, I don't wanna just get out of there and have a freak out, but I kinda was. But I just remembered Kelly, just get grounded, I closed my eyes, and then I just concentrated on my seat and actually the singer's voice, because it was really good. And then I was good. So, it's interesting for me. And you mentioned LED, but I've been having a thing with cooking, and it's a certain time, I finally am getting a clue, like, okay, it seems to happen at 20 or 25 minutes where it starts ramping up. And I think it's a lot of the moving, and I do clean and wash dishes, so I have the water running. And then the noise of the whatever I'm cooking in the frying pan. And then of course TV in the background. So I'm super hypersensitive right now. I'm like just at that stage where everything's bothering me. The blinds with the light coming through, it's bothering me right now. But
I think for that, if you're feeling it at like, oh, I do fine for 20 minutes, and then like the 25 is where that's you hitting the threshold.
Yeah.
And it's endurance. It's kind of like, okay, your body can tolerate a little bit. So that's where I would just be saying, obviously when you're cooking, you have to be safer. But you might just want to take like, okay, it's been 15 minutes, I'm gonna do a quick grounding.
Yes.
And then I can hopefully drop it a little bit to be able to do 15 minutes.
and I'm
Versus 25 minutes in one duration.
so now instead of chopping, prepping, doing all of it in 1 hour's time, I am doing preparing.
That stuff is hard because those are lifestyle modifications. And all of us across the planet struggle with that stuff the most. But what I'm trying to encourage you guys is these are changes you might have to do temporarily for your long-term recovery. It's usually not forever changes. I think that's just the apprehension part of that is like, what? I'm never gonna be able to stand for longer than 25 minutes. No, right now, you have to pace through it, but eventually, as you build that tolerance, it's going to improve. I think there's been a few people that have mentioned like, hey, I was doing great, and then wait a minute, now I'm having like somewhat of a relapse. That can happen, okay? The brain is very intricate, and it can learn to adapt to it, learns to compensate for things, and it gets used to that noxious stimuli. But any of us, if as therapists are like, have you done your home program? Are you doing your home program? It's a question I would ask you.
No.
You've been doing your home program, even if it's been years since I've seen you, and in a sense, because that home program is there to maintain that stimulation, maintain that level of activity or not interfere. It's very common to have like regressions for various reasons. For acoustic neuroma, I would be like, have you had your follow-up, MRIs to make sure that, those have been okay. If it's migraines, it's okay, like, have you had a recent change in any of like those triggers? It can be age related. As we age, we naturally start to rely on our vision a little bit more and more. For females in particular, if you have a hormonal component to your migraines, as we age, there are times in our life that are very, like pregnancy, pre-menopause, menopause, and that can change things too. It can be, did you have an injury? Or maybe you're walking differently to protect that. So there's so many different reasons why you guys can go into, somewhat of a kind of regression. But that's where I'd be saying it's important to me that you guys don't wait too long to get back in, because it's so much easier to treat these things when it's like, okay, it hasn't been years of me feeling this way. It's, hey, I'm kind of starting to feel like my balance isn't up to par. I'm a little bit more cautious, or I'm not really tolerating these things as well as I used to. When you're starting to have that internal conversation, that's time to get back to the doctor and say, even if you're not with that same doctor, say, I need a referral to therapy that's helped you in the past, and give us a call. So I hope it was useful. Essentially, I better not say
I mean, if you guys remember that chart that Jen had up there with the circles and then anxiety, fatigue, dissociation, and the other side of it was what? The neck, the cervical spine. So yeah, when we do have regressions or, relapse, coming back into physical therapy to get your neck work done could be really, really helpful because sometimes it's those stiffness, on your neck muscles, your joints that could be causing the nausea, the dizziness and stuff like that too. I kind of like to think of it as we have blood going up to our brain and our neck is the only pathway that the blood could go up there. After we use that blood and we replenish our brain with oxygen, we have to flush it out. But if our neck is really stiff, sometimes it doesn't work that well. So we have to flush out the waste too. So sometimes I like to think of it that way, that's the reason why I work on the neck. But another reason why I work on the neck is you're dizzy, so you stop moving your neck again. And so now your neck is stiff. And that stiffness could cause, other, like, you could start getting nausea, getting headaches, you can't sleep well because of the sleep, you're getting more dizzy the next day. There's so many factors that come into the neck and that we could help. And so, yeah, don't wait too long because the longer you wait, you're neuroplasticity, that what we just talked about, things like that will change again. And so we don't want that to happen. If you guys could do your home exercise and get better, that's great, and do that. Sometimes, some of you that's been here for about a year or longer, I have patients that have been a patient of mine for 5 years. It doesn't mean that they've been coming for 5 years. It means every 3 months they come back for a checkup, just to make sure that they're okay. Or they only come when they have increased symptoms, and then we just manage that again. Once they're better, they're off therapy again. We do have telehealth here. So for the patients that are on Zoom, today we had actually 24 guests on Zoom, which is pretty good. Total attendance was almost 45, which is really good. For those who are on Zoom, we do have telehealth for patients that are, out of this area. So we will, as long as you're in California, because our license is in California, so we could help patients in California. But if it's, can we only help patients in California? Yeah, I'm not sure about that. But yeah, we could help through telehealth as well. So.
I have one more kind of quick question. I'm just curious, speaking of neck problems, which I have, don't so good. I wish you would still here. But how many people with PPPD have disassociativeness to some extent or another, which I have? That bothers me perhaps even more than the dizziness and or neck problems as well.
Can you describe your dissociativeness?
Okay.
Dissociation.
I feel either it's improved a little bit from 7 years ago, but more likely I've just adapted to it and it's just become my new sad norm. But I feel a little bit as if I'm in a movie, like there's an unreal quality to everything that is not pleasant. And even though, this is going to seem like a funny analogy, even though with PPPD you don't normally have round and round, vertigo, and it's maybe more like this or floating. So I get nervous the dissociative part, I feel like in describing it to somebody, either I'm sort of walking on a boat, or when you were a little kid, you like to twirl, and the moment that you're almost right, that the round and round stops, but there's like a second or two where it stops spinning, but you're not quite right. That is where I'm stuck at, I feel like. When I'm not incredibly symptomatic, then my baseline is like a 3, but then with COVID shot, another booster, I got a symptom that I hadn't had, which was vertigo. And after 3 days, it dissipated, but it's up to my baseline to look before now. And I don't even know if that's permanent. So I'm just wondering about dissociativeness, if you feel like an unreal quality all the time and or math problems.
What I felt is that, you know, the way I describe it is like, you know, those old cartoons where they did one figure of one,
Oh,
and then
yes.
and eventually, you know, you flip through the book and then you
Exactly.
see the cartoon moving. Well, that's how I feel, like my body is moving and then I stop and then something behind me catches up with me. And then I'm like, okay, I think I get it.
That's an interesting analogy to describe.
That's how I describe it to Kelly a lot of times, where like, okay, Kelly, I feel like, you know, I'm moving and then behind me is like all the other Martha's coming in behind me. And then, you know, it catches up with me. So yeah, that's to me like the dissociated part of it, because I'll be floating, and then all of a sudden, bang, it hits me and I'm like, okay. So that's.
What else?
I have that as well, and to me, it's like when you're at a playground and you're going to step onto the bridge section of the playground, and all of a sudden you have to use more thoughtful movements and make sure my legs are a little farther apart, and just I really think about how I move my body and how I'm walking when that heightens. Carpet patterns do that to me, like when I started back to yoga, and when I leave yoga, they have the dumbest carpet, big splotches of different color, and it's like, oh boy, I almost want to tiptoe, is that the same depth? But when I do that, I just adjust my body, but it's a weird feeling, and it's always there a little bit, but sometimes it gets much worse.
I'll say that for me, I call it more of a brain fog, or like a feeling like if I have like slightly like blurry goggles on, and I'm just kind of walking through the world, and like you said, it doesn't feel real, but obviously it is, we're real, but yeah, it just feels like a fuzziness that's over my brain constantly. So yeah, I understand what you're going through.
Thank you. This is so nice because I haven't talked to anybody else really, but so we're all unique.
Sometimes they describe the dissociation kind of like Alice in Wonderland syndrome. You guys ever hear of that? So it's kind of like a dreamlike state where sometimes things look bigger than it does or smaller than it does. You don't feel like with yourself. You're kind of looking at yourself in third person, and things are catching up to you. It doesn't feel clear. It's foggy brain. So there's a term for that. We call it Alice in Wonderland syndrome, and that's part of PPPD and migraine associated vertigo as well.
I think that has a lot to do with like the anxiety aspect of it as well, because I have been in therapy, not physical therapy, but you know, speaking with somebody about this, just because I feel like it helps with the anxiety. And they kind of told me that when your mind is just so stressed out all the time, that's its coping mechanism, is to kind of disassociate.
To put distance between you and your problem.
Yes,
Well,
yeah.
That's very interesting.
Yeah, it's like a coping mechanism to help you get through the stressful time that your mind and your body is going through. That's what they explained to me. I don't know if that's 100% accurate, but that's why I think most of us who have 3PD kind of have that similar symptom, because we're all always very anxious about it for the most part.
Okay, thanks. Thank you guys, everyone, for sharing. Right now it's 11 o'clock. I made a promise to everybody and myself. We're going to respect everyone's times. We're going to end the support group meeting at this time. But we don't know when our next support group meeting is going to be. We don't know when it's going to be or what topic we're going to have it at. But please keep your emails. Keep looking at it. If we do send an email, message out, please come again. Let your family members know. Let your friends know. Please let your doctors know about our clinic. That's all we ask. But yeah, if you guys need help, please call our office and let them know that you've been to this workshop. If you guys want a consult visit and not an eval visit, we offer that too. So if you're still on the fence about starting therapy and and you wanna talk to one of the therapists about it, free 30-minute consult, we will offer that for the members that are here, so please call us, and if you guys have any questions, you could email us, and please remember to leave your email address if you want the slides that Jen had for the workshop today.
Is there anything you'd like us to give our doctors other than a business card?
Yes, if you are gonna go to your doctor soon, please see us, and I'll give you like a packet of stuff that you could take. But we do have our vestibular program brochures, so that they can know about our specialty. And then a prescription pad would be helpful, yeah.
I just want to close by saying thank you guys for coming, whether it had been in person or online. We get told this every single day of like, am I alone? And I'm like, because of HIPAA, I can't tell you, but you're surrounded by, people that, have a good understanding, not only of what you're going through, but not only in your therapist, but, I think that this is really important for you guys to have that community and feel safe and feel like you guys can discuss that and be around people that really understand what you're going through. So, thank you guys for taking your Saturday morning to spend with us as well.
Thank you.
Thank you guys. Thank you.
Nice to meet you, and like we said, we're not alone.